Good evening. Today I will talking about the interventional treatment by TACE and PVE under Angio CT. This is my hospital. This is my hospital, founded for more than 100 years. This is our new building. My new building just opened about 1.5 years, and after we move into the new building, we also have the new machine. This one is one of our new machines, the Toshiba Angio CT. We use this new machine for the TACE cases mainly, and also use in the Y90 cases and the CT guidance cases and some difficult PVE cases. In the TACE cases, how we do the TACE, this is our TACE protocol by the Angio CT. We do the celiac angiogram first, and then we do the CT-AP. CT-AP is a CT of the portal face, which we place the catheter at the SMA, and we inject the contrast medium and wait until the contrast get into the portal vein and do the CT scan. And then we do the CT-HA. CT-HA is a CT of the hepatic artery. So we can do via the common hepatic artery or hepatic artery proper or right hepatic artery or left hepatic artery. So we can see the hepatic artery from the CT-HA. And then we do the 3D reconstruction of the CT-HA and do the 3D road mapping. And then we super selection into the feeding arteries and do the chemoembolization and do the post-embolization CT. This is an example. At first, we do the celiac angiogram for looking at the anatomy of the celiac artery, and you can see the mass, the HCC is here. And then we do the CT-AP and the CT-HA. CT-AP, you can see that the liver parenchyma is enhancement, but the tumor is not enhanced because the tumor is not fed by the portal vein. The tumor fed by the hepatic artery. And the CT-HA, you can see the tumor is enhancement, but the liver parenchyma is less enhancement. And then we do the 3D reconstruction of the CT-HA. You can see the hepatic artery clearly. And then we select the vessel, we trace the axial CT to finding the feeding artery of the mass, and then we mark at the feeding artery. You can see the green spot is a marker, and then the marker will show in the 3D image automatically. So we can know that this vessel is a feeding artery. And then we can use the 3D imaging for road mapping when we select super selection into the artery. After we super selection into the feeding arteries, we do the chemoembolization, and then we do the post-embolization CT. You can see the lipidol staining. This is an example video. We trace the axial CT and put a marker at the feeding artery. And then the marker will show on the 3D image, and you can find the angle that you can see the vessel most clearly. And then you move the fluoroscopy in the same angle and use the 3D image for road mapping when you select into the vessel. This is the same case, and then we embolization that vessel, and then we move to another vessel that feeds another tumor here. We mark again at the feeding artery, and then we move into the angle that we can see the artery clearly. And then we use the auto angle to move the fluoroscopy into the same angle that we move automatically. And then we select the microcatheter into the feeding artery. Okay. The advantage of the Angio CT, at first, is a high sensitivity in detecting HCC. 2, clearly seen of all feeding arteries. 3, helping in recognition of extrahepatic arteries. 4, knowing the area or the organ that the artery supply. This is example cases. The first case, female 68-year-old with HCC. MRI show 7.3 centimeter HCC at segment 8 and 3.4 HCC at the segment 3. This is a large HCC here, and this is a small one at the segment 3. This case, we do the first TACE 1 month after MRI. This is a celiac angiogram. You can see the large HCC is here, and the small one is here. It's a segment 3. So we do the CTAP and the CTHA. We can see the large tumor clearly, and the small one is the segment 3 clearly. But there is other multiple small HCC in both hepatic lobe. So maybe it's a new one, maybe the new HCC after the MRI. So the CTAP and the CTHA can be see the HCC clearly. It's high sensitivity in detecting of the HCC. And then we do the 3D reconstruction of the CTHA and finding the feeding artery. At the first TACE, we do at the largest one only. We finding the feeding artery into the largest one, and we selecting super selective into the feeding artery of the largest HCC. And this is a post-embolization CT. You can see the good lipidal staining in the largest HCC. And then we appoint to do the second TACE 1 month after first TACE. We do in another HCC in both hepatic lobe. We use the same technique as the first TACE. We do the CTAP again, CTHA again, and we super selective into the multiple feeding arteries. This is a post-embolization CT. You can see good lipidal staining in the large one, in the mass at the segment 3, and multiple areas in both hepatic lobes. And this is a follow-up MRI 1 month after TACE. The plain CT showing the good lipidal staining into the mass, and there is also the small nodules of the lipidal staining also, and the MRI showing no residual viable tumor. If you can see, the lipidal staining nodule is less than the nodule that we see on the CTHA and the CTAP. So maybe some of the nodule, some tiny nodule that is not staining of the lipidal. But the MRI cannot be detect the nodules. So maybe the MRI is not sensitive, is not sensitive enough to detect the tiny HCC. But the CTHA and the CTAP can detect. In this case, we can clearly see in all of the feeding arteries, so we can complete embolization of all feeding arteries in only 2 times of the TACE. The other case, the second case, the male 60 years old, the CT shows 9 centimeter HCC at segment 4A/8 and 2 centimeter HCC adjacent to the IVC. This is a 9 centimeter HCC here, and the small one is here, adjacent to the IVC. We do the first TACE 1 month after TACE. This is a celiac angiogram. Maybe the large HCC is here, and the small one is here. Then we do the CTAP and the CTHA. You can see that we can see the tumor clearly. This is a large HCC, and this is a small one, and the CTHA, this is a small one. In this case, you can see that on the CTHA, which we do via the right hepatic artery, there is the enhancing defect at the anterior aspect of the large HCC here. So it means this area is not fed by right hepatic artery, or maybe it's fed by left hepatic artery or extra hepatic artery. So the enhancing defect on the CTHA is helping in recognition of the extra hepatic feeding arteries. In this case, we do the angiogram of the right inferior phrenic artery, and we can see that it enhancement the tumor, and we do the CTA of the right inferior phrenic artery is enhancement at the anterior aspect of the tumor. And you can know the area of the tumor fed by right inferior phrenic before doing the chemoembolization. In this case, we think that its enhancement at the area that is the defect on the CTHA, so we embolization only in the right inferior phrenic and the branch of the right hepatic artery. But follow-up MRI 1 month after TACE, you can see there is only partial lipid staining in the large HCC, and the MRI showing much residual tumor here. Then we appoint to do the second TACE. 1 month after the MRI, we do the CTAP and the CTHA again. Now we do via the hepatic artery proper. You can see the enhancing area here as compared with the CTAP. And we do the angiogram of the right inferior phrenic artery is already occluded. So we trace the CTHA. The feeding artery is from the medial branch of left hepatic artery and the small branch of the anterior branch of right hepatic artery. So we select into these feeding arteries, and then we do the chemoembolization. You can see there is a good lipid staining in the large tumor. So in the PVE cases, we usually use the glue embolization of the PVE, and the simple case of the PVE, we usually use the conventional angiogram only. We usually do the PVE in Angio CT only in the case of the difficult case. This is an example of the case of the PVE. This case is a female, 68 years old, with a hilar cholangiocarcinoma. The CT shows bilateral intrahepatic duct dilatation, and there is enhanced thick wall of the bile duct at the hilar region. The surgeon consults for right PVE and the PVE of the segment 4 because the surgeon wants to do the extended right hepatectomy. He wants to resect the right hepatic lobe and also the segment 4. In this case, we look at the CT scan before doing the PVE. There is several medial branch of left hepatic artery, so we decided to do the PVE under the Angio CT. The PVE, in this case, after we place the catheter in the portal vein, we do the CT portography, and you can see we can see the branch of the portal vein clearly, and there is many branch of the medial branch of left portal vein. So we trace the axial CT for finding which one is a medial branch of the portal vein, and then we embolize the branch that we see on the axial CT. We super selective into each branch of the medial branch of the portal vein, of the left portal veins, and when we do the glue embolization in each branch. And then we do the glue embolization in posterior and anterior branch of right portal vein, and this is a post-embolization image. CT 1 month after the PVE showing there is a glue in the medial branch of the left portal vein, and the left portal vein is still patent, and the main portal vein is still patent, and The lateral segment of the left hepatic lobe is larger than the previous CT. So, conclusion. The TACE, the advantage of the Angio CT is first, it's a high sensitivity in detect of the HCC and clearly seeing all of the feeding arteries and helping in recognition of the extra hepatic feeding and knowing the area or the organ that the artery supply before doing the chemoembolization. And in the PVE case, we can clearly identify the branches of the portal vein, so we can do the difficult cases of the PVE. So the Angio CT now is clear. Thank you.